identified. The only point about this is the current Banff classification to show you that it defines a number of different categories, sort of 1 to 5 or 1 to 6, normal-looking tissue, antibody-mediated rejection, and how that's defined. Not that you need to know the details of it, but there are hallmarks of that, and the hallmarks of antibody-mediated rejection is peritubular, peritubular capillaritis. Then there is both acute and chronic antibody-mediated rejection. Then there's borderline rejection, and then there's acute T-cell mediated rejection. Again, emphasising the point that our therapies target these organs. And the hallmark of cell-mediated or T-cell mediated rejection is tubulitis as opposed to peritubular capillaritis, which is one of the hallmarks of antibody-mediated rejection. And then there's chronic T-cell mediated rejection as defined by the pathology, and then there's chronic changes. And the other point I want to make is the more recent Banff classification changes that antibody-mediated rejection now requires 3 levels of criteria: histological criteria, evidence that antibody interaction with endothelium is occurring with or without C4d, and serological evidence of donor-specific antibodies, meaning these antibodies that we've just defined by Luminex, which defines antibody-mediated rejection and determines our therapies. Some examples here. This is just a T-cell mediated rejection response. The cells that I showed you that get activated with tubules overrun with T-cells. And the hallmark is tubulitis. In other words, cells invading the basement membrane and into tubules and overrunning tubules. That's the hallmark of cell-mediated rejection in renal pathology. More examples showing the tubules and cells invading the tubules, or tubulitis. The cell-mediated rejection can even involve vessels. You can see endothelium and vessel wall being invaded. This has got a worse prognosis when vessels are involved with cell-mediated rejection. Again, these stained cells are all T cells. You see this terrible look in endothelium and invasion of the endothelium and vasculature. And this is showing glomerulitis and peritubular capillaritis, which is a hallmark of antibody-mediated rejection that you require to make that diagnosis, which puts in place a whole different type of therapy and targeted therapy, which you need to target the antibody and the B cells as opposed to T cells. Okay, so now just a bit about pharmacology to try, and I'll go through this fairly quickly because a lot of this is known and you'll have the lecture notes, but you know, calcineurin inhibitors, cyclosporin and tacrolimus, it's well known how these work. These bind to cyclophilin, and we know that signal 1, that calcineurin is a phosphatase molecule that binds to calmodulin and calcium to dephosphorylate this so-called transcriptional factor NFAT, or nuclear factor of activated T cells. That then, once it's dephosphorylated, moves to the nucleus as a transcriptional activator of cytokines. Cyclosporin gets into the cell, binds cyclophilin, and inhibits this complex. So, and that's how it works. And this molecule that it binds to become activated is a so-called cyclophilin. Now, tacrolimus does exactly the same thing, but the binding protein is this FK binding protein 12, which then binds to form and inhibit calcineurin, and is a potent inhibitor of signal 1 and a potent inhibitor of cytokine secretion. Mycophenolate, on the other hand, works late. Mycophenolate is a reversible inhibitor of inosine monophosphate dehydrogenase. It's used in transplantation. It's used in a whole host of immunological diseases. And it's a potent inhibitor of this inosine monophosphate dehydrogenase, which is important in de novo the guanosine nucleotide synthesis pathway. So it's a direct inhibitor of cell replication at the DNA level. Now, a few things about mycophenolate that you're probably important to know about. Firstly, mycophenolate is absorbed and is taken up and is converted to mycophenolic acid, or MPA. This is the active form of mycophenolate. Gets into the circulation, and it's this that acts on lymphocytes to inhibit. But importantly, mycophenolic acid enters the enterohepatic circulation and gets a glucuronide molecule sucked to it, or MPAG, which is is inactive. However, the MPAG is renally excreted. That's fine, but MPAG also enters through the enterohepatic circulation, gets back into the gut, and through gut flora gets converted back to mycophenolic acid, and then enters the enterohepatic circulation. And so what you can see there, that if you do get accumulation of MPAG, as in renal impairment, you can get excess amounts of mycophenolic acid being produced. That's the first thing. And when you look at that enterohepatic circulation, it's what produces this second peak when you get the initial absorption of MPA production, followed by this secondary peak, which is the enterohepatic circulation. Now, it's important for two reasons. One is when you're using it with cyclosporin, that produces a reduction in MPA, or mycophenolic acid exposure, through inhibiting that enterohepatic circulation. And number two, that enterohepatic circulation with the MPAG production, which is renally excreted, with renal failure, you get accumulation of the MPAG, which then goes back through the enterohepatic circulation and produces more MPA back through the gut flora with the conversion. And so when your GFR falls below 30, consideration needs to be given to dose reduction, although we don't always do that. But it is important to realise that your patient with renal failure and mycophenolic acid and mycophenolate is going to be increasingly immunosuppressed through higher levels of MPA. Monitoring. Do we monitor? Look, I don't want to go into this in detail other than to say that the jury is still out. There are a number of studies that looked at whether therapeutic drug monitoring with cyclosporin and tacrolimus, yes, we do monitor. With mycophenolic acid or mycophenolate, the jury is still out. 3 studies, and one of them has shown that with fixed dosing as opposed to concentration-controlled or therapeutic drug monitoring, that you can, if you target, reduce your rejection rates. 2 other studies, although I won't go into the details, flawed in some areas, have not shown a benefit. However, I think at the moment the jury is still out. We do need more prospective studies. We generally, not all units, although we do, monitor, do therapeutic drug monitoring for mycophenolate, as there is studies to suggest that there is a relationship between low exposure to mycophenolic acid and rejection rates. So I think that as I said, the jury is still out, but I suspect as time goes on, we're going to be able to show that, in fact, probably in certain scenarios that we probably should be monitoring therapeutically the MPA, although that's a personal opinion as opposed to standard therapy. Now, the mTOR inhibitors, sirolimus being one. Now, that's an interesting one because that's now coming very much into fashion. Sirolimus is one, the other one is everolimus, gets into the cell, and interestingly, the binding protein for sirolimus is this FK binding protein 12, which is exactly what tacrolimus binds to. Remember, in tacrolimus and sirolimus are macrolides like erythromycin, and they bind to this FK binding protein 12, which is what FK binds to. However, it doesn't inhibit calcineurin. It actually inhibits this target of rapamycin signalling molecule. So that's one important point, and it does go through, it is metabolized to the cytochrome P450, and so there is all those drug interactions associated with that. The mTOR inhibitors, I'll show you how we use these clinically in a moment, but they are anti-proliferatives. They do arrest through inhibiting cell proliferation, both immune and non-immune cells, so T cells, B cells, and so they are immunosuppressive, but they also block non-T cells, fibroblasts, and so they do impair wound healing. So you've got to be very careful when you're using this drug and you've got someone who's having major elective surgery, whether you decide to change them from that. And as the other good example where it's used for its non-immunological effects is, these drug-eluting stents. That's the drug that's used in the drug-eluting stents to inhibit or reduce the rate of stenosis. Its anti-proliferative properties has also been proven to be of benefit in malignancies, and it's got an anti-cancer property through probably also anti-angiogenesis effect through reduced VEGF levels, and the oncologists also use it. So it's got an attractive use in transplantation, as you know, and I'll show you that malignancy is a major problem for our long-term patients. And it's also got anti-proliferative and antiviral properties in vitro, and in fact in the studies it does indeed in some studies translate to lower rates, I should say, of CMV infections. Just to say, its use, for example, it's got certain specific use, for example, in tuberous sclerosis, and you know that in tuberous sclerosis, the tumour repressor genes are defective. That then leads to overactivity of mTOR, which leads to tumour growth. And so it's got a specific use in tuberous sclerosis, in angiomyolipomas and other tuberous sclerosis-related tumours through this mTOR pathway, which is specifically overactive in patients with tuberous sclerosis due to these repressor genes being defective. And just to show that it is used by the oncologists in a whole host of cancers, which I'm not going to go into, but the notes are there for you to have a look at. So some of the clinical issues, just there for this last part, what are some of the clinical issues with that immunosuppressive drugs, how we use them, and how we can personalise some of this therapy, and how we can prevent rejection. Now, the first thing to say that what are some of the clinical problems? Well, firstly, long-term allograft loss still is a major clinical problem. What are the causes of long-term allograft loss? Well, firstly, we know that it is multifactorial, but it is due to immunological causes. So in other words, long-term slow allograft response and our alloactivation, which the pathways I've showed you earlier. and part of it due to probably the calcineurin inhibitors, which we know are nephrotoxic. We thought that some years ago that it was CNI toxicity was a major factor. Probably still is a factor, but we now know that immunological causes of chronic allograft loss is probably more important. The other cause for long-term allograft loss is death with a functioning graft. In other words, patients dying with a functioning graft. What do they die from? Cardiovascular disease and malignancy. And so you can see where it may be attractive to start using things like mTOR inhibitors in our immunosuppressive protocols. Recurrent disease, diseases such as focal sclerosis, IgA, and BK and BK nephropathy. Just to show, this is ANZ data. This is our registry that we've got in Australia, New Zealand Dialysis Transplant Registry. This showing graft loss, showing the reasons for that, and you can see that death with a functioning graft is a major cause, as is chronic allograft nephropathy, and I've showed you the reasons for that. So this is now borne out in our registry data. To show you that graft loss, if you break that down, the cause of graft loss and death with a functioning graft, cardiovascular being important, cancer being important, and infections in our immunosuppressed patients. And chronic allograft loss, which I indicated was largely due to immunological reasons, and also probably from calcineurin inhibitor toxicity or nephrotoxicity. This just goes to show you patient survival for the Australian New Zealand population. This is the Australian population showing that years and patient survival. You can see that over the years that we have gotten better in managing our patients with better survival rates. At 10 years, we're getting 80% or more patient survival, which is significantly better than remaining on dialysis. Allograft and allograft loss, and I just showed you the reasons for this allograft loss and for the patient loss on the previous one, that we have got better and better and better with our immunosuppression, with better short-term survival at least, but you can see that we still are losing these grafts steadily over that time. So still not perfect, and the reasons for that is that,